I will begin by introducing our fabulous moderator, Dr. Lauren Ritchie. Dr. Ritchie is a board-certified infectious disease physician, with mostly a decade of experience in HIV minority care and clinical research, armed with a biology degree from UNC, Chapel Hill. She earned an MPH from Johns Hopkins and a medical degree from Thomas Jefferson University. Her residency and fellowship at Tulane University completed by a certificate in clinical medicine, laid the foundation for her expertise. Starting as an assistant professor at NUSC in 2013, she ascended to associate professor in 2017 before joining LSU Health Sciences Center in 2017. By 2018, she became the ID Center Director and achieved professor status in July 2023. As an active infectious disease Society of America member and fellow, Dr. Ritchie contributes to IDSA's Journal Club writing and engages with the HIV-MA's Ryan White Coalition since 2021. Juggling inpatient and outpatient clinical roles, she dedicates herself to teaching and mentoring infectious disease fellows and internal medicine residents. Her research focal points include HIV linkage and retention and care, with additional interests in quality improvement and comorbidities like substance and alcohol use disorders. Dr. Ritchie's impactful contributions include 17 peer-reviewed papers and over 45 national posters and presentations on HIV. So I'll give Dr. Ritchie a hand.
I'd like to introduce our panelist. Simultaneously, he serves as a major in the U.S. Army Reserves, contributing as an Army dentist. He is a proud alumni of Howard University College of Dentistry, and he honed his skills through general dentistry residencies at St. Elizabeth Hospital in Washington, D.C., and LSU Health Sciences Center. His commitment to healthcare and military service reflect a dynamic professional journey marked by leadership, specialized training, and a dedication to providing dental care in both the civilian and military context. So, very excited to have Dr. Brown here today. Next panelist is Dr. Nguyen. Dr. Nguyen is a general dentist who has been working at the Infectious Disease Dental Clinic for the past 4 years. She graduated from the LSU School of Dentistry in 2014. Prior to working at our ID Dental Clinic here and on the third floor in the outpatient tower, she worked at various practices in Louisiana and Alabama, and she is glad to be able to provide dental services to patients in need. Next on our panel, we have Dr. Louis Manning, who is a OBGYN generalist who has newly joined the Ochsner Medical Center on the West Bank campus after finishing his residency at the University of Louisville earlier this year. He provides full-spectrum reproductive health care services and is interested in taking care of patients with HIV and hepatitis C, as well as PrEP use among people assigned female at birth. Prior to starting medical school at LSU New Orleans, he worked in various capacities at Priority Healthcare and Crescent Care in HIV testing and linkage to care. So thank you for being here. So our last panelist closest to me here is Dr. Cuffey. Dr. Damian Cuffey is a 2008 Xavier University of Louisiana graduate and is a seasoned professional serving as faculty in the LSU Diagnostic Services and in the Infectious Disease Clinic since 2018. With a dental degree from Meharry Medical School in 2016, he earned accolades such as being a Robert Wood Johnson Health Policy Scholar. Dr. Cuffey has contributed significantly to public health in Louisiana, focusing on disease management and earning a master's in public health in 2010. His commitment extends to serving as a major in the U.S. Army National Guard for the past 9 years, showcasing a career marked by dental expertise, public health dedication, and military service, reflecting a passion for multifaceted contributions. So, wow, that is an amazing panel in front of us here today to talk about HIV-related stigma. So first question from my panelists is just to tell me a little bit about your professional role, either current or past, and in that role, how you interact with people with HIV.
I'm Dr. Damian Cuffey. In the past, my role with patients with HIV, I worked for the state in disease management following my degree in public health. We were charged with capturing patients who were out of care. Back then, out of care was considered patients who hadn't been seen by their provider within the last 6 months. And so we created a system where when the patient were to check into any hospital or clinic, there would be a ding, and that would alert us to the patient that was out of care so that we were able to contact them and call them. And so I did that for about 2 years prior to dental school. And then once after dental school and residency, I came on staff at the infectious disease dental clinic where I'm a general dentist. And so I provide comprehensive dental care to patients living with HIV.
I'm Louis Monig. I'm like I said, OBGYN at Auction on the West Bank. And I just see general OBGYN patients of all ages who have the routine, health needs and need screenings. That includes a wide variety of folks. And in my prior to medical training, I had worked in a couple of different capacities at Crescent Care and Priority Healthcare on the West Bank, primarily in HIV testing and counseling, referrals and linkage to care as needed. Did a lot of community engagement work, screenings, going to venues and testing out at bars, restaurants, community events. And then went to medical school here at LSU and thought I was going to be an infectious disease physician, but then realized what I really like to do is just to talk about sex all day. So I became an OBGYN, and I'm happy to be back here in New Orleans and hoping to make this part of what I do and the care I provide every day. And I am not an expert, and I'm also here to learn as much as everyone else is. So I'm happy to be here.
Hi, I'm Angela Nguyen. I'm one of the general dentists in the ID dental clinic. So my the HIV experience journey kind of started with dental school. So I went to LSU dental school, and we have a rotation in ID dental, and that's where we kind of stay here for a week and then just learn how to treat HIV patients, making sure that we're well prepared whenever we see them in private practice. I saw some HIV in private practice, and I'm back here at the ID dental clinic. We're also are all assistant professors at the LSU Dental School. So now we're introducing the dental students to patients with treating patients with infectious diseases and HIV, and that's patients.
Hello, I'm Dr. Brown. I am the director of the HIV dental clinic here, the ID dental clinic. Been in this position for roughly about 10 years. Our clinic provides comprehensive dental care to all of our patients, and all of whom are living with HIV. Another aspect of that job is, as Dr. Nguyen mentioned, we are technically professors at the LSU Dental School. So on 2 days out of the week, we had dental students come and assist us with seeing the patients for them to get that experience and exposure of treating our patient population as well. So that's kind of what we do 9 to 5 here, right at the ACB building.
The next question is, how have you seen stigma related to HIV in the medical community evolve over time? And, not everyone has to answer, but if you have a good response, feel free to respond to that question.
With this question, I was actually thinking more about how it's evolved in medical training, and I'm glad that Dr. Ritchie mentioned this grant she has now to incorporate more training into education of future physicians. But there's this tension in medical training, dentistry, doctors, nursing school, all that.
Recording in progress.
Where there are these high-stake exams you have to take, and you must pass them in order to practice. And it doesn't matter if you ace all of your actual courses. If you don't pass these board exams, you can't practice. And a lot of times the content of these are a couple of years behind what's actually happening in medicine. And so, the job of our professors is to both, get us up to date on what's actually happening in the world, but also make sure we can pass these exams so we can get out there and do this. So a lot of times our testing is geared towards what we might see on these standardized tests. And I have seen, questions that are written to make us, think, okay, this NOSS men presents to clinic, what you should do. The answer is you should test them for HIV. And I actually brought this up to a professor, and I saw this, and I said, this seems really out of date. And they're like, yeah, actually, we wrote this when ART was first coming out, and this is a really old test question, and we just, hasn't been brought up to us to change this, So I think over time, and sort of the work Dr. Rucci is going to start doing is things are starting to get a little bit more modern. I think I had one slide on PrEP at the end of the lecture. I just said, this is the thing, and it didn't really get into much of what it is and how long it's been around and where it's going. So I think as, the education changes and things are more updated and more modernized, we'll see this change a little bit in future providers, but it's going to be probably a long haul before we really, are seeing big changes in the workforce.
As far as the current state of the stigma and possibly reducing it, I kind of feel like what we do particularly kind of aids in reducing that stigma. Particularly I think about which Doc mentioned before, is education would be the primary word I would say to kind of address that situation, whether it's educating the populace in general, educating the providers. The kind of the purpose of this type of event will kind of qualify, but also as our new dentists come through, educating them, kind of informing them of the advancements in medication, maybe alleviating some of their concerns as well, kind of all plays a part in that. And just like when I mentioned educating the populace, talking about marketing, I mentioned PrEP as well. I think with people just being aware of kind of what's going on in the demo can kind of assist in reducing that stigma and kind of moving the ball forward a little bit.
The next question I wanted to ask is, what strategies do you currently employ in your practice to combat HIV-related stigma?
Well, I'll go first. Again, our setting is kind of unique because all of our patients are currently living with HIV. Like I mentioned about the students. Also, we try to conduct an interdisciplinary space with the other dental clinics. We're separate from the infectious disease clinic. We're kind of all with the dental clinic. So us, oral surgery, general practice, residency, we kind of create a community where we all seeing patients. And I think that kind of exposes providers to different things. It kind of helps reduce it. That's kind of what we do.
I've been trying to do, and I see people who come in for a variety of things like annual wellness exams, problem visits, worried about a possible exposure to something. And when people want to talk about, I want an STD screening, I at least try to say, okay, if you're worried about a possible exposure, then let's check for these 5 things. And HIV is always one of them. I tell people, if you were worried about an exposure from a partner, it could be any of these things. HIV is no different. So I try to, in the language I use, talk about it like it is another infection. It's something we can screen for. We can treat if it's detected. And I'm sure all in this room, it's not what it would have been 20, 30 years ago. Because I feel like, someone's out going to say, we can also test for, syphilis, HIV, sometimes people might get, I don't think I'm at risk for that. So I try to, with my language, just kind of couch it all into, we're just going to do all these things if you're worried about this because, it's all transmitted the same way. So that's one thing I've been trying to incorporate lately.
I would say, as far as myself, I'm a pretty down-to-earth provider, and I think that with our patients, sometimes they're so accustomed to being talked at that they don't realize that we're regular people as well. So I try to make them feel comfortable with myself. I'm a human, I'm a person. I might see you outside on Saturday or a Sunday at the second line. I want to speak to you. I think that's been something that I've been employing since I've been here, is just increasing the comfort level with the patients to interact, ask us questions, talk to us as if we are one of their peers and not somebody who is like a provider who is way up here and they're down here. So I think that's one of the biggest things that I've been doing is making the patients feel comfortable. Sometimes they get a little too comfortable, but at least they're comfortable and they can talk to me. They can tell me how they feel and I can talk, back to them as well. So
thank you. And it sounds like one of the things that came up there was the concept of opt-out testing, which is something that's been recommended for a long time, that when screening is offered, it's offered to everyone and it's offered as opt-out. So here are the tests I want to do. And most of the time I found that when I offer the test that way, people agree to them. It becomes more, we have more people not wanting something when you're like, oh, do you think you need to be screened for this? Because really, it's not the patient's job to figure out what they need to be screened for. It's our job to recommend it. And the CDC has recommended for a long time HIV testing, and the U.S. Preventative Task Force has put that recommendation in place since 2015. So that means insurance generally covers the testing too. We all know there's free testing menus. So let me ask another question, why do you think it is important to combat stigma, and how is it important as a provider to know the HIV status of your patient? So I'm going to answer this a little bit personally and pass on to you guys. I'm also an infectious disease provider, and I see patients in the hospital who may not have HIV. But it's very important for me to know if someone has HIV and to know kind of where their immune system is, because that helps me to figure out what kind of infections to look for. So when we create an environment where people do not feel comfortable sharing their status, we're going to see poor health outcomes because information is being withheld. So that's why it's extremely important for us to create an environment where people feel comfortable to tell us all of their medical problems so that we can use that information to make the best diagnosis and treatment plan. So again, the question was, why do you think it's important to combat stigma, and how is it important to you as a provider to know the HIV status of your patient?
What I was actually thinking about it over here is that stigma not just related to HIV or PrEP use is, carries over to a lot of different parts of medicine. And I was actually thinking about gynecology. There's a lot of I guess some people are a lot of shame about their bodies and think some things are normal, don't even know about it. And there's a lot of stigma for thinking something is strange or it's unusual prevents folks from coming to the doctor's office to be examined. And a lot of times just a fear of, coming and addressing it and letting someone see can lead to worse outcomes down the line. Need more complicated treatment or surgery or even early death. So we see a lot with cervical cancer, people not wanting to come for pap smears, being afraid of pap smears is that something that could be easily taken care of, the snowballs, and 30 years later it becomes a whole bigger issue. So stigma keeps people from getting services and screenings and care they need, and it exists throughout medicine. And so that's one of the huge things I think about why it's so important to combat stigma, and I don't know the best ways to do that. And I'm open to hearing things, thoughts, ideas from all y'all out here, especially your experiences and what you felt. And I remember a story also from when I was in college, and I was I think I got exposed to HIV possibly. I made an appointment with a campus health doctor. And I just let him do this whole okay, things look good. And then at the very last second, I was like, oh, can I get an HIV test? But I never brought it up, never mentioned it. And I was so afraid to ask for it. So I was, afraid that I would be judged, that I was just well, I guess I'm not going to get that test today. So I'm it's important to create or try to have an environment where there's as little stigma as possible, or you're not feeling that. So you can be honest. And that kind of segues into why it's important for us and knowing HIV status to be very important for your obstetrician or gynecologist, as it might change the recommendations for different screenings that might be recommended. I might need a screening more frequently than would have without HIV, just because our affects their immune system
It can affect, for a pregnant person, whether they're able to give birth, vaginally, or C-section might be required, be as aware of the viral load is. So for us, it's like we're not nosy and we're not, we know because we are going to talk about you, but it actually changed a lot of how we might approach your healthcare and what we might recommend just based on your health status. That, like I'm sure she was saying.
I think like if we can have like an open conversation about like, everyone's health, it definitely helps providers treat their patients like better in a way where I guess we assume that like most people are all like healthy, but I think some people are not, and we want to make sure that we provide like the right care, like if we take out teeth, that they're not going to have a infection afterwards and end up in the hospital because of carelessness. So I think it's important to just be cautious, like how to give all the information to the provider so that they could be cautious and just make sure that they're providing the best treatment so that everyone can heal well from their procedures. And okay.
Being aware of the status as a provider, particularly in dentistry, is important because, for one, it kind of helps create a more complete picture. When we're trying to create differential diagnoses and there's certain oral manifestations of disease, that kind of helps us to just treat the patient in a more accurate way, particularly with dentistry, being aware of status, labs, that type of thing. At our clinic, we require various labs within a certain amount of time in order to treat the patients properly, primarily because we want to make sure we are aware of potential of post-operative infection, post-operative delayed healing, also bleeding. There's a correlation between HIV and thrombocytopenia. So being aware of someone's status and the condition in the recent labs can kind of help to prevent like some more adverse reactions from happening post-operatively. So that's how it affects us as dentists.
Thank you. And I think we all know that the data supports that when people feel a lot of stigma, they often don't seek care. And that's extremely important, especially for people with HIV. They have a strong, healthy relationship with their provider. And I think anybody who provides care at HIV knows it. There are just little things like knowing the person at the lab or being seen in the waiting room or things that can just turn people away from coming to the clinic and seeing us. It's their fear that other people will see them. We even lose people who are diagnosed in the ER and only have to walk. It was like a couple of 100 yards to our clinic, and they disappear inside the condition because of their fear. So I wanted to open up some questions from the audience for this panel.
I'm Mitch Andrich. I'm a nurse practitioner working in HIV. I'm also HIV positive, and I've been to a lot of private dentists, and I've had a lot of dental work, a lot of different dentists, and I've never felt stigmatized, and I've always been completely open with my HIV status. So I'm wondering if when people say they're experiencing stigma when they go to the dentist or they go to the GYN, if it's perceived stigma because of what's being done and what's routine. So as a medical professional, I know that my dentists are going to double glove. I know they're going to wear a face mask. I know that that's procedure, that's standard procedure, but the patients may not know that you do that with everybody, whether they have HIV or not. So I'm wondering, and one example I had at my clinic recently was I had a patient coming in for the first time. She does deal with a lot of stigma issues. And her first comment when I went into the room was, "I don't think your medical assistant likes me." And I said, "Oh, she's wonderful." I said, why do you feel that way? And it was during COVID, and we were still masking at the clinic and that kind of stuff. And she said that the reason was because the medical assistant had her mask pulled down, not on her mouth and nose. And when she came out the room, and she was next to the medical assistant pulled up her mask. She assumed that was because she was scared of her. And I told her, I said, no, we're supposed to be all wearing masks. And she was just doing that because that's the procedure. So I'm wondering if there's things that we can do in the setting that we don't think are stigmatizing, but the patients may think that we're scared of them because we're doing these things.
I would agree a little bit of what you're saying about like that perceived of how the patient may feel. We've actually had patients who said the same thing, who may have made the accusation, not knowing the setting that we work in. So I think sometimes it can be perceived, but if I'm being completely transparent, I worked in different places. I worked in upstate New York, where it's not at all professional, but some providers, this was years ago, I graduated from dental school 20 years ago. I remember when I first graduated, I worked in certain private practice settings where there was an actual stigma. Granted, that was a long time ago, and I would like to think people are more informed now. So to your point, I agree that in some cases it may be perceived, but I've seen personally that sometimes it is a true stigma. Even the idea of double gloving is not necessarily like, it's called universal precautions. We just kind of treat everybody, follow the same methods as far as PPE, that type of thing. So even that I would maybe kind of gently push back on, with that being like the standard of care. But each provider does everything differently. I'm not saying anything specifically, but I think it's a little bit of both. Even in 2023, there's perceived stigma, but that as an actual stigma still persisting, I think.
And I just agree to that. That made me think of a poster that's in our clinic about the scales. It says we weigh in kilograms for patients AD. And I never really thought about that, how just things that are very normal to us might come off to someone that's like, oh, they're putting gloves on because they don't want to touch me, but, I put on gloves for everyone. So, there might be room for something like that in clinical spaces, like we glove for patient safety, something about that messaging like that, so that posts aren't feel like they're singled out. But I never thought about that before, so thanks for bringing that up.
I would say, to your point, there is somewhat of a perceived stigma, right? Because I'm not sure what your dentist looks like if you guys are of the same demographic. Sometimes, from what I've learned, is that you get better health outcomes or more patients following directions when they can identify and they can understand their provider, they're comfortable with their provider. So, for instance, I applaud university for such a diverse staff, right? So our patient population looks like us. So if they say, well, I prefer a female provider because I'm comfortable with her, or I prefer an African-American male provider because I'm comfortable with him, that can reduce some of that stigma they may have. If I were to go to a provider and I have HIV and it's an older guy from back in the day, he's gonna look at me and say, oh, well, you were out here doing X, Y, Z, and this is this. So I might feel uncomfortable with that person or that provider. So I think what university has done to kind of reduce some of that for our patients is to give them care with providers who look like us, right? So I think that also is something we have to think about when it comes to our patients' stigma and how they feel. And even I have some patients who are of my demographic who don't feel comfortable with me treating them because they're like, oh, I know him. He might know somebody I know. I see him at the bar or what have you. So I don't want to see him, So I think we have to think about that as well. Like when we're servicing and providing care for our patients, like what we look like in the room to them, and as opposed to what they look like. Then.
Yeah, and I'm glad to hear that today your providers were not stigmatizing. But I don't really have heard from patients for dentists or someplace where they face stigma. My own private dentist, I remember filling out the form, and one of the questions was, are you around people with HIV? And I wrote all day, every day. But I don't really understand how that question would work with my dental care. And I imagine that if I was a person with HIV and I saw that question, how would I feel answering that question? And how is that? I can't see how being around people with HIV would affect my dental care unless I have HIV. Maybe is this relevant might be discussed. But how about the audience? Any questions or comments?
So I just have a question. I'm kind of piggybacking off of the previous one, but I'm wondering, we're kind of discussing now more internalized stigma as opposed to in certain cases being experienced stigma. So is there anything that you guys, I mean, aside from the demographic thing, which is fantastic, but is there anything you guys might do kind of on a day-to-day basis to address the internalized stigma that may not be experienced, but you're just noticing it in patients?
Well, one thing I can say from my providers is that we are all linked together, and we do have a robust psychiatry and psychology service for patients that are willing to meet and do therapy to discuss stigma-related issues. But panelists, do you have combating internal stigma is very challenging.
So I don't think I have a great answer for that, but one thing I kind of touched on earlier is I try to create a space where I at least mention HIV so that if someone's thinking about it or worrying about it, whether they should bring it up or not, I've at least said that word already in the clinical space, and that maybe creates room for them to say, oh, actually, there is one thing, kind of going back to why I was afraid to bring it up in a clinical setting. Because it could just be very helpful to hear that, to see that somewhere, to know that, okay, I think I can bring that up here. This might be a, safe location for me to discuss that. One thing that I think that I do for internalized stigma, being a dentist, people come to our operatories and our chairs and they lay back and they want to talk about anything and everything. So I allow them to talk. I allow them to just express how they feel or what's on their mind. I remember I had a patient who quietly mentions that they were positive. And I knew they were positive because we're in the HIV, but I say, well, okay, that's cool. I just made them feel comfortable, letting them know I'm not concerned that, I know what's going on, but I want you to feel comfortable knowing that I'm going to treat you had I known that you were positive or didn't know that you were positive. And I just want you to feel comfortable. Again, that's the comfort thing. So sometimes the internalized stigma comes from being made to feel uncomfortable about your status. And so I just, when they want to talk, let's just talk about it. If they bring up something as opposed to that, I try to do a little bit of education as well. And I think that's kind of what I try to do. But it's difficult being a dentist. All we can do is, oral stuff, but yeah.
It was mentioned earlier about patients perceiving stigma from not just their clinicians, but medical assistants, front desk staff, things like that. And so
Recording in progress.
all of you are providers, but in what ways do you think you as providers can help facilitate reducing stigma with the rest of your clinic staff? Because we have all of you here, but, and you guys work with patients living with HIV, but, you might have a new medical assistant or a front desk person who has not had that experience. So in what ways do you think you guys can help create a safer environment for your patients?
That's a great question. As far as our support staff, dental assistants, medical assistants, well, my first reaction to that question is, in our particular case, our assistants have been around so long that because of their knowledge, level of comfort, and their rapport with the patients, our situation is a little bit different because we have assistants who've been there 20, 30 years and are very, they actually communicate better with the patient than us sometimes. Sometimes there's a little barrier. I'm sure you understand that. So in our case, that is not usually the norm. But if we did have a new provider, I think it goes back to education would be the primary thing. If we had a new team member, which occasionally we do, but our staff, we have, most of it. And even to the other question about the stigma and how we do that or internalized stigma, because we've been around so long, when I see a patient and let them know I've been in this position for 10 years, I've been treating this fibrillation for 10 years, the setting that I remind them of the setting that we're in, that kind of reduces, maybe some anxiety or internal stigma they may have by reminding them of the setting and reminding them of the comfort level and of the experience we have, right? And then the knowledge that we have with Dr. Cuffey, having an MPH, and just having a knowledgeable staff. I think that kind of like can reduce that from the patient. Also, our support staff as well. I think they kind of follow our lead a little bit, and kind of the culture that we set kind of helps a little bit as well.
I've worked out in private practice, and I mean, we see like some HIV patients before, but I think whenever it comes to support staff, it's like them not really like understanding about like HIV. So it'd be good to like give them an introduction or a lecture about like HIV, how to care for it, how to manage it, and just, you know, get people educated and comfortable with just seeing patients. Because our like all of our patients have in our clinic, we treat all HIV patients, and all of our staff, like, they are comfortable with it. They understand, mainly because they understand the process, like how to, you know, whatever all the patients go through, what labs to look for to make sure that like they remind us how, you know, remind us like ways to treat patient, what to be careful of and stuff. So I think education is just like really key to making sure everybody feels comfortable with treating HIV patients and seeing that.
And I agree with that. Kind of us setting the expectations and trying to meet about our best foot forward is a good way to hopefully help that kind of permeate in the clinical space. And I haven't seen that many people live with HIV in my clinic, but we had a couple of transgender patients, a couple patients coming in talking about pregnancy options, which are limited in Louisiana. But I try to check in with like my med assistant and say, hey, like this we were talking about, this is what they asked about, this time that I put it laid out. And I'm pretty lucky that I have one that's like very like chill and like down to earth and wants to know about these things. So I just try to kind of bring them into the fold of what this means and what that care looks like for this person. And you know, hope that they're cool with all that, and they'll stay around and they'll, you know, continue to, you know, work with us and make a good environment.
Yeah, also to answer that question, you know, when I hire staff for my clinic, which is a HAP clinic upstairs, the first process is the interview process, and I ask very pointed questions about different types of people, and you can usually tell right away if somebody is uncomfortable with a certain group of people, and that would be the kind of person who I want to hire. I want somebody who is able to interact with every patient without any bias. And then once they're hired, we do education about HIV. So our nurses are AIDS certified nurses, but our support staff also do training, which is always afforded through the ADTC, so that they understand the basics of HIV as well as U equals U and treatment as prevention. So I think those are all pieces of making sure your staff doesn't have stigma towards patients. But you know, I think that there's always going to be staff that get through, that have those things, and you have to listen to the patients, you know. And it's correct that sometimes it's internal, but sometimes it's external. And you have to listen to the complaints and put them together. And sometimes it's just not a good fit. And you have to be willing to accept that maybe that person wasn't the right hire. So it's so important. One staff member, if that person turns away, you know, a handful of people, then that's a huge loss for us. So we want to keep people on care. So that's kind of how I address that as well in my clinic.
Hi, everyone. My name's Nick Ginos, and I'm a public health analyst with NNPHI, National Network Public Health Institutes. So I was thinking about what Mitch had brought up, perceived stigma, and maybe one way to combat perceived stigma. Maybe it's a suggestion and then more of a question as well from our great panelists here. But maybe one way to address perceived stigma would be to just talk about it head on. Dr. Mooney mentioned that he tries to find a way to work HIV in. But if one of your patients comes in, they've listed that they're HIV positive. Maybe there's a point there where you come in and you acknowledge that they're HIV positive and say, hey, you know, thank you for letting us know this information. It's very important for your care. I'm gonna wear 2 gloves, or I'm gonna do certain procedures, but I do that for all my patients. It has nothing to do with your status. I just want to acknowledge that up front. And because I think one of the problems I keep hearing with stigma, especially in clinical settings, is perceived stigma and just beating around the bush, not acknowledging the elephant in the room. And that leads to more chances for stigma to break out. Instead of just acknowledging up front that there's possibility here, and then how can we address it from the get-go. So I'm definitely interested to hear what ideas from clinicians, especially since most of you do work in HIV clinics. I'm trying to think for, non-clinical spaces. I mean, it's not like this, no, I'm not racist kind of mentality or something like that. It's more, it's being a little more poignant with your, and straightforward your position there.
But I guess one of the also things I try to practice is I kind of briefly go through the history they have listed. I'll say, headaches, knee surgery, if they have HIV listed, saying living with HIV, and kind of like see how they respond to that. Kind of would want to play by ear how they're feeling, because if okay, it'll see your prior issues, getting your medicine, kind of ask about everything and give later prescriptions. So I guess I mentioned it a bit earlier, but I think there's a power in just naming things, and I don't want to put it on the patient I'm wearing 2 gloves just to everyone. There may be a space for that if I can sense the patient seems uneasy or seems nervous around me, but also if someone is very not worried about their HIV status, not worried about HIV positive status, then I'll just continue and roll on the usual continuity routines. I would probably based on what the person's looking like and responding to my questions.
Yeah, so I guess that's acknowledgement, verbal acknowledgement versus sort of normalization and just.
I don't want to put my own thoughts and values onto their experience and see anything about them, but hopefully try to let them sort of be that experience a little bit as well.
Sorry.
Just short answer, I kind of agree with you about being direct and frank with those discussions. Like I said, in our setting, even, patients come in with that perceived stigma. But for us, it's every day. It's not, we really, truly, I would say to our staff, work in a space that's very welcoming, and we don't have those issues on a day-to-day basis. So our conversations are very frank and direct, and this is, why we're asking these questions. And I think for people in a different type of setting, being direct and also explaining why this is relevant and moving on, not making, it awkward or anxiety filled, just very direct, frank, explain the reason why and move on.
In my culture, HIV is frowned upon. How do we begin to educate the community and also our co-workers with HIV? How do we begin to break down that stigma in that community?
There's a multifaceted answer to that. One thing that maybe hasn't been mentioned is we talked about education in various methods. Specifically, I know as young providers or maybe inexperienced providers, there's a concern about transmission. So being educated about that, talking about the statistics behind that, can at least be a component of that. Like I said, a lot of other things that were mentioned today as far as societal norms, but as far as one thing that we can do in at least a provider setting is discussing some of those or getting to the bottom of maybe fears of providers of treating certain type of patients.
one thing I'm thinking of in terms of messaging about reproductive issues is storytelling and patient experiences. And you're seeing a lot of lawsuits about X, Y, and Z experiences patients had because of certain laws out there. And I feel like people change attitudes when they can connect it to a person or a friend, family member, relative. So like Dr. Rishi is, bringing her patients to be medical students, and maybe the first time they've seen someone that had HIV in their lives, it's just they're a normal person. So I think what we're trying to do with this summit, in terms of what's the stigma, is just talking, saying words, being visible, and I think connecting things like HIV and PrEP to real people and being open about it is an important way that we can continue to do this and have people realize, people live with HIV are all over the place. They're all has their different members, and you may not know because they have been afraid to say something. You have to take like stigma, so education and education definitely.
I would say in addition to the education and communication piece, there's also the advocacy word. And I've been involved with some of that through the HIV and AIDS, Ryan White Medical Providers Coalition, and I've met with staffers for our senators and their representatives about HIV-related issues and advocating for continued and increased funding for Ryan White. And also probably a really important thing, I'm going to bring Mitch in, sorry to call you out, Mitch Handry. But we have the HIV Hepatitis C Commission for the governor, which is another large advocacy group that works on eliminating some of the laws that we have in Louisiana, or at least as much as we can in the environment they have, to decrease stigma on and legal sons as well as advocate.
It's really, really, really tough. In the state that we live in, we're an extremely conservative state. New Orleans is separate from everybody else in Louisiana. And so it's been really frustrating in dealing with the legislature in the other states. One thing that the commission is trying to do this year is to make ourselves known better to the legislature. We monitor all the bills that are coming out every year, and we either support or oppose those bills, and we contact the legislatures to let them know our stance on it. And then specifically if we feel it's something that's going to affect HIV or hepatitis. And one thing we're trying to do this year is become more engaged with the legislature so they know who we are. Because we have some really, really important people on the commission that are very, very high up in their positions. But they don't, I think the legislature doesn't know that. So when they get a letter from us, they don't really take it to heart. But it's still a really, really hard battle. So it's very, very important. And I hate politics. I really hate politics. But being in the position that I've been in, I've been forced to become involved in politics and watch it. And it's just, it's so important that we all go vote and that we pay attention to who we're voting for and what their voting history is like and has been, and what they're saying that they're standing up for or against, and then holding them accountable to that. So it's very important that we do though, and we do let our legislatures know how we feel as individuals, so we can try to get some of the laws and stuff that are criminalizing HIV change.
Yeah, so I think the summary is education, educating new providers, advocacy both on the state and national level, communication in the room with patients and with our non-physician providers as well, staff in the clinic. But yeah, I think combating HIV-related stigma is a big, huge issue. And advocacy is going to be a big part of that. So thank you, Mitch, for everybody that worked for the commission, which is open to the public for anyone who wants to attend the meetings.
Basically, I've been having HIV for 8 years. I've been undetectable the whole time. And they say how to deal with the stigma of HIV. Basically, I was speaking for people that have HIV. To deal with it is basically treat us like you would treat any other human being, as if they had, like, if we had cancer or high blood pressure, like through diabetes. Treat us like an individual human being. Don't look at us and treat us like, oh, that person has something that I don't want. Because we know that other people don't want this. We have to live with this on a daily basis, and every day we have to deal with that. And it's hard to deal with mentally, emotionally, physically, and psychologically. So just treat us like anybody else needs to be treated as an individual. Treat us like we would treat your loved ones. Treat us like we treat your friends. Because at the end of the day, we are human too. We just want to be loved and respected. It's a choice that we made. It was, some of us didn't even make that choice. It was made for us. And we have to carry this every day. So I'm just asking people to just look at us like you would look at people that you would love and people that you would respect as human beings. Thank you.
My name is George Nowas. I'm a clerical associate professor, faculty at Xavier University of Louisiana. Thank you for the amazing panelists and moderation, Dr. Witchy. Quick question. We bump into patients a lot in our, when we're practicing. They're not coming to HIV, they're coming for other things. And we notice that they have syphilis, they have any kind of another STI, and we have that conversation with them to try to make sure that they have PrEP access and all of that after we confirm, of course, that they're HIV negative. But a lot of these patients tell us that they've tried to discuss PrEP with their physicians, and their PCPs have thrown them off with that request. So my question to you is, how can we improve this? How can we have primary care physicians feel confident enough to be able to support their patients who are asking for PrEP? Because now we know patients who are asking for PrEP are candidates for PrEP or guidelines. So my question is, how can you improve that with primary care physicians?
Yeah, so in order for PrEP to be available, firstly, it would have to be available in the primary care. And that has been a challenge. I know I have a colleague doing research project to try to expand PrEP in the primary care clinics. It's not an easy endeavor. You have a lot of older providers that are sort of stuck in their ways, and we kind of feel that not everybody leads to be in an infectious disease clinic because there's huge capacity issues and shortages. Panelists, do you have any comments on expanding PrEP? PrEP, I don't think it's going to expand to dentistry, but I think that's it to you.
And this is something that I've struggled with my field because, people talk to us about, their, sexual activity, drug use, all these things that, or just like wanting to be on PrEP. And I think it's going to take some time, and it's the more folks that come out of training who know about it, who are comfortable providing it. I try to make myself available as someone who can be referred to, or you can ask questions about PrEP, and just making that known amongst folks in the area that if you have questions, I'm happy to answer for you. Like ACOG, which is like governing body of OBGYNs, has put out statements that, they fully supported and fully support OBGYNs being PrEP providers, but just a lot of getting used to a new thing, learning new protocols. There's no barrier to us doing it besides, us actively trying to do it and make it a part of our practice. So I think just having folks who do prescribe PrEP are comfortable with it, making themselves known as resources to both patients and their colleagues to either refer to or to learn from is just something that we need to be vocal about. And it's just, I was going to bring this up earlier, but I forgot to, but, we have 15 minutes to see patients. I run through so many things. I try to make sure that their screenings and the testing you're asking about and the mammogram, pap smear, all this stuff. And I try to at least, do STI testing. But if sometimes it just gets, passed over. But if someone were to bring up PrEP to me, I would stop what I'm doing and say, great, let's talk about this. Because clearly he wanted, and I want to help you with that. But I know it's hard too. There's a power differential with clinicians in clinical settings. But I just try to be as open and responsive as I can for folks who are seeking that. Not really good answer, but just more of my thoughts on the issue.
As a dentist, no, I don't think we'll be prescribing PrEP for our patients, but I am on PrEP myself. And I think the way that we improve or increase the amount of PrEP that our patients or patients in general, the population, has access to is I do train, as Dr. Rishi said, some of the older population, they say, oh, that's just if you're homosexual, if you don't need it, that's totally untrue, right? So the younger providers that are coming out of training, that are in this community, they are the ones who are more comfortable for providing those medications for us in general. So I think when it comes to the training piece, that's what is needed is, for us that are coming out of school, we're teaching our future providers that, okay, if a person asks for this medication or what have you, you should listen to them. You should be comfortable in providing that service for them. And so I guess to help patients out of the community, we should, maybe have a list of providers in the community that's comfortable prescribing PrEP, different clinics that they may be able to go to with insurance or without insurance or what have you. So that's my 2 cents.
That's an excellent point. And that it is part of the curriculum for the medical students now, with the expectation that any person in specialty would know what PrEP is. I suspect in certain specialties like neurosurgery that probably not be prescribing the PrEP, but at least they'll understand it, know what it is. And those going into primary care type fields should be more familiar with PrEP now that it's being taught at the primary medical school level.
So in my role, I do a lot of training of people who are like new to being writers, being in the healthcare field. And something that I struggle with is kind of like wanting to get the future of our healthier workforce in front of people who are living with HIV or who are using drugs who are vulnerable. And also I don't want to use human beings as teaching, right? They're humans, and they're humans who are experiencing an extraordinary burden already, right? And so how do you kind of walk that fine line of exposing students without, you know what I'm saying? Really messing with a vulnerable population of using food games.
I will say that's a cool question because we are in a teaching hospital, and we have the 4th-year dental student coming out, the residents. And they assist us in seeing our patient. I think, it's hard. It's hard to answer that question.
Maybe the supervision piece.
Yeah.
It's their exposure. My medical students too, their exposure is with me supervising them. I will supervise the encounter, so that makes them more comfortable with the encounter and not making sure they're not doing something for the same patient, albeit from our care.
I have had people look at the HIV who want to do that work also, so they get some folks who are willing to do that and, will value that experience and, want to be part of that. So I agree, it's easy for people. They're not, instead, thanks to other people that are experiences, us that are speaking our terms of finding folks who want to talk about it and willing to do so is important too.
I think it just comes down to your professional judgment as a provider. Like I say, kind of what we do, we have our D4 senior dental students that rotate through our clinic. I think it's just kind of knowing your patient and knowing which patients are more comfortable than others. Certain patients are, it's in their personality and their DNA to be an advocate. I have patients in the room right now, amazing patients, whom would be more ideal for that type of setting. as opposed to others who maybe are not, right? I wouldn't want to do it in a way where we want to educate our staff or exploit our patients, for lack of a better word. I think it just comes from just experience and judgment. I mean, not the best answer, but just like my honest answer, just from doing it for a long time and reading patients and talking to them, you kind of see which patients that would be more ideal on than others and who understand big picture why this is important.
Yeah, and I agree with that. That's part of what I do in my clinic. And there are therapies of that month that we should see stop and follow the next story and be part of that. And there are others that don't. I know that students say that it has to be, I want to expose the student, but I also want a patient who's willing to be part of that.
I was thinking that of basically our patient population, knowing your patients, right? And there are some patients who are willing, knowing your patient populations. And there are some patients who are willing to allow students in the room. And so I think that's important as a supervising provider or faculty, just saying, okay, well, this patient is okay with having students there. They don't feel like they're getting paid. Then you do have some patients who feel like, okay, well, I'm not sure. I don't want a student working on me, They're also educating the patients sometimes. You say, well, I was a student at one point in time, and I need the training, and we're supervising and we're guiding them, and we want them to be comfortable treating whatever population they have to treat.
Thank you guys so much. This has been a really interactive audience. I'd like to thank Dr. Brown, Dr. Nguyen, Dr. Manning, and Dr. Kabi for their participation on this panel. And thank you so much.